muted so that we can hear everyone. And we're going to go ahead and get started then. So you can go ahead and go to the next slide. Yeah, that's perfect. A little technical difficulty. We'll go back a few slides. There were a couple slides that you should have seen at the very beginning that just talk you through some of the aspects of Zoom. Yeah, or if you want to go to those, that would be great. But a couple of things, we have a lot of people that are here from all the regions of the United States and outside of the United States. So when we, get to those slides where we show where you're from, please wave and let us know that you're here. We'd love to sort of meet you. Again, if you unmute at any point today to ask a question or to, share any kind of information, please remember your protected health information. So don't share your child's name or your location or anything that can really identify the child. And again, let's try to stay muted so that we can, everybody can hear. And then again, we're going to have poll questions like we've done in the last 2 sessions if you've been with us. So please fill out the polls, answer or questions so that we can learn more about you and what you're looking for. All right, next slide. And we're just going to walk through Zoom again. So again, if you see a red bar over your microphone, that means we can't hear you. So please stay muted. If you see a red bar over your video, that means we cannot see you. Please, share your video, your video so we can see you. We love to see people who are on here. We are a community of learners, so it's nice to see everybody else who's in the session. If you have a question, feel free to use the chat function, and we will be happy to help you with technical assistance or questions or anything else you might need. Next slide. And then resources. You're going to have access to the resources and slides from today's session. So we'll talk about that toward the end of the session, and you'll receive an email with all of those resources from today's session at the end, and probably within the next 48 hours at the conclusion of today. So you will get resources. Next slide. And then again, we are part of Project Echo. We're all about moving knowledge, not patients. And we do this through a lot of case-based discussion. We do this also through, presentation, like we're going to do on ADHD today. So we're going to follow the format of Echo so that, we have some consistency in what we do here. So you're going to see us follow the same format every time. So feel free to participate along the way where you can. Next slide. One of the things we'd like you to do again is, share your name on the slide. You can put your first name, maybe where you're from would be great. If you're from a different state or different country, please list that. So again, we can get to learn who you are. Next slide. And then again, today's agenda, we're going to do some poll questions. I'm going to make sure you meet all of our experts who are on our hub team so that you can get to know them and their backgrounds and their work in autism, which is pretty substantial. We're going to see who you are here today. We're going to do a case presentation where we're really going to walk through a case of a child who does have ADHD with some of our hub team members, talk about questions and recommendations we might have for that case, and then really get into the topic of ADHD. And then we'll have some other time for questions and discussions toward the end. Next slide. Next slide. And we're going to start off with our hub team members. So Amanda, you want to kick us off?
Sure. Hi, everyone. I'm Amanda Bennett. I'm a developmental behavioral pediatrician at Children's Hospital of Philadelphia, and really happy to be here today. Lisa, you're up.
Hello, everyone. Lisa Nowinski, and I'm from the Mass General Hospital Lurie Center, just outside of Boston, Massachusetts. And I'll pass it to Eric.
Hi, Lisa. Thanks. Hi, everyone. I'm Eric Booter. I'm Chief of Psychology here at Nationwide Children's Hospital and one of the primary investigators in the Autism Care Network. And I'll have the privilege of saying a lot more about Dr. Nowinski and Dr. Bennett later today. Glad you're all here. And I'll hand it off to Sapna Shetty.
Hi, everyone. I'm a couples and family therapist at the Child Development Center of Children's Hospital. So excited to be here today with everyone. And I will pass it on to Andrew.
Thank you, Sapna. My name is Andrew Nelson. I'm director of the Autism Speaks Autism Response Team. We're here today to help provide any resources or tools you might need. So off to you, Amy.
Hi, everyone. Amy Hess again. I'm here at Nationwide Children's Hospital in Columbus, Ohio. I am the family partner with the Autism Care Network, as well as with our hospital here, and it's great to see all of you. Josh is not here today, so I'm going to hand it over to Sabrina.
Hi, everyone. I'm Sabrina Long, a clinical social worker at Nationwide Children's Hospital. Passing it to Cody.
Thanks, Sabrina. Hey, everybody, I'm Cody Hostetler. I'm a psychologist who works in a primary care office here at Nationwide Children's Hospital in Columbus, Ohio. Ellen, you're up next.
Hi, everyone. My name is Ellen Geib. I am a psychologist as well at Nationwide Children's Hospital. I'm also a sibling partner. I have 2 younger siblings with autism. I'm not sure if Dr. Neumeier is here right now. Lindsay Bartram.
Hey everybody, I'm Lindsay Bartram. I'm a developmental behavioral pediatrician here at Nationwide Children's Hospital, and I will pass it on to Angie if she's here. If not, we'll go to the next slide. No, next slide.
Okay, so in the chat, we'll be here from the autism response team. We're going to be looking for any questions you might have about local resources or providers in your area. And my team and I will be watching for any ways that we can support you and get you those resources quickly, either through the chat immediately, or we'll schedule a time when we can communicate with you after the event. And it's myself today and Fatima Allen. Thank you.
Hi, everyone. This is Nancy, part of your tech support team today, and we're here, so please reach out to any of us with support in the front of our name if you've got any challenges.
Hi, everyone. I'm Melissa, part of the ECHO support team. Welcome.
Hi, I'm Maura. I'm part of the ECHO support team too. Welcome, everyone.
We're excited to have people from all over the country with us today. We have people from West Coast, we have people from the East Coast, the Midwest, Southeast, South, Southwest. We're kind of represented all over the country today, so it's good to have people.
Cody, I have to jump in here and say I saw somebody from Alaska, so I'm pretty excited.
We did get Alaska. Yes, we got Alaska. And on the next slide, you'll see that it's not just the United States, though. We have people from 9 different countries who are with us too. So please send a big wave to us if you're coming from outside the United States.
All right, next slide. So again, Family Echo, we really, the design and the goal of this is, we really want to share medical and behavioral information that we know here in the clinics. And we want to make sure that we get it to you because we know it's helpful in raising a child with autism. As a family partner, I have a child with autism. I've been able to work with a lot of these hub team members and in a clinic environment for a long time. So I've really learned a lot about healthcare and behavioral health treatments. And we really wanted to focus this so that we can give that information to you so you can use it in your homes and with your families. Next slide. We really understand that families are partners in care. And I think that, making sure that we all have the information so that we can build really quality care and treatment teams is really what our goal is. And, your voice is really equal and valuable in all the healthcare processes and pathways that you're going to choose for your child. So again, we want to make sure we give you as much information as possible on that. So take what you learned today back into your own homes, back to other families that back to your healthcare providers, and give it back to your community as much as you can. So we really want you to share what you've learned so that we can continue to have the learning go, just beyond our clinics and our homes. So we're so glad that you're here today. Next slide, Ellen.
Thank you. Well, you may hear us use different terms when we think about autism and families and as we go through our Family Echo presentations. And I wonder if you've heard of some of these terms, such as person with autism spectrum disorder, or autistic individual. You may hear terms like neurodivergent or diagnostic terms in the past, such as Asperger's syndrome. I said I have younger siblings with autism. And you may hear us say autistic individual. And what this is starting to get at is the difference between person first and identity first language. At its core, person first language may sound like person with autism and refers to the person first. And I've noticed, and I think my family as well, that this type of language helps to emphasize maybe the humanity of a person. And then autistic person refers to identity first language. And what that may be referring to is that autism is really a part of someone's identity, an inherent part of them. And we can think of these examples in our everyday life too. So we've chosen to use some terms, like we don't say person with deafness, we say a deaf person. And in our everyday life, I wouldn't call myself, say, a person who plays soccer. I would call myself a soccer player. And each of these terms are important because language is important. Language and how we refer to one another is very important when we think about how we relate to one another. Words matter and identities matter because people matter. And I'm finding myself really in the middle of both of these types of language, person first and identity first language. I think we need to be gracious and patient with one another. I've gotten it wrong, and I see that both person first language and identity first language have one thing in common, and that's that they care about the individual and that person has value in their personhood and in their identity. And so I'd like you to join us because you may hear a little bit of both of these terms in our presentations, and we can learn more together. So next slide.
Cody?
All right, y'all. So we have some poll questions for you guys. We just want to get a little bit of information about autism and ADHD and the interaction between the two. So if people could respond to the poll questions that popped up on the screen, we'd be curious to see what you guys think already. Good, we have some responses rolling in already. We got one answer on the first question. We're going to give you some time to read over the questions and to think and respond. Up to 10 already. We're already getting some big trends on the first one and some more split decisions on the second one, it looks like. You can see people working through them as well.
My poll keeps disappearing.
Yeah, I think somebody accidentally ended it, so we're gonna relaunch it and see if we can gather some. We'll give it we'll give you guys another like 30, 40 seconds to get your answers in. So if you already answered, re-answer again. We're gonna start a whole new clean poll. And if anyone sees a red button that says end poll, don't touch it. I know it's tempting, but please don't.
Look at everybody. I appreciate everybody responding.
I'm doing it twice right now, but it's resetting and sending me a new one again.
We're already back up to 50%, y'all. Thank you so much for doing that.
Excellent. All right, give it another like 10, 15 seconds. I'd like to get as many responses as possible. This really helps us to understand what your needs are. So the more information you give us on these, the better. It will really help to help us to design the next series and the next content and the resources that we're going to send your way.
I can tell you that we're used to redoing and redoing things, so no problem doing it again.
Thank you very much,
Thank you
Carrie.
so much.
ECHO is a community of learners, so we all get to learn. All right.
All right, looks like about three quarters of people have responded.
All right, let's kick this over to Lindsay and Sabrina then.
Okay. So I will start out by talking about a case that for a kiddo I'm pretty familiar with. So this is an 8-year-old girl. We're going to call her Jane. She has a history of autism. She's otherwise a pretty healthy girl, doesn't have any other diagnoses. She was diagnosed with autism at about age 4. And the family did complete about a year of behavioral treatment with an ABA therapist when she was younger, kind of right after her diagnosis. And that really helped with kind of their primary concerns at the time, which was, sorry, hold on just a second. My computer had a little, I'm not sure what was happening with it, a seizure of some sort. But they were having a lot of tantrum behaviors. And so that really helped out a lot. The family had some really great behavior strategies that they had been using. But over the course of the past year, so starting at about age 7, she really had a lot of worsening behaviors that were coming up at school, especially. So parents were saying they were seeing similar things, but really school is where they were having more problems. So specifically, she was getting in a lot more trouble, which was pretty rare for her. She's a fairly happy-go-lucky kid, but she was being disruptive in class. She wasn't able to maintain her attention for more than about 4 to 5 minutes at a time, whereas before that wasn't quite as much of a problem. And she was really having a lot of difficulty staying seated. Her grades were falling, and she was having to utilize a lot more breaks and calm down time at school. So the teachers were also reporting that they were having to do a lot of redirection, which was, compared to the previous school year, pretty different for her. All right, so just a little bit of background about the family in general. They do live in rural Appalachia. They are a few hours away from our clinic, so it's typically a long drive getting to us. She lives with her mom and dad and an older sister. They do live on a farm. They raise chickens. They raise their own eggs that they sell at the farmer's market. Dad works at a local bank. Mom is a stay-at-home mom. They do have one vehicle that they use between the two of them, and sometimes that can make it challenging to make it to appointments and things like that. In her school, she does have an IEP with speech, behavior plan, utilization of resource room, and really had been doing great with those supports until this year, which was 2nd grade for her. Let's see, you can go to the next slide. So we talked about most of that stuff already. I will say, speaking of medications, she wasn't on anything at the time these concerns came up. There were no other new symptoms, no neurological concerns. Once upon a time, when she was much younger and had first been diagnosed, she had tried a medicine called guanfacine for some aggression, and that really didn't seem to help as much as her behavioral intervention was helping. Caused her to be too sleepy, so family had discontinued it. Other than that, she's never been on any medications for any behavioral concerns. She does have an older sister that was diagnosed with ADHD in 1st grade and is doing quite well on medication. She also has a first cousin on dad's side that has an ADHD diagnosis and also a learning disability in reading. And so as we were talking through this, mom and dad's question is, could she also have ADHD? Because it's presenting a little differently than it did in her sister, who doesn't have autism, but they were seeing some similarities. Or is this totally a different issue? Like, is there something going on with school and learning that we maybe haven't identified yet? And so that's really the crux of the family's question when we saw them.
Lindsay, who has questions for Lindsay?
I'm not sure if this question's related, but I did put it in the chat. By the way, hello, my name is Adrian from California. I'm kind of going through that right now with determining if it's more than autism. Is it a learning disability? Is it dyslexia? Is it ADD? And navigating through that. So I didn't, just to kind of bring that up, it sounds like it might be related to this, but like, what's the best avenue to navigate this? We went through our healthcare right now, and my wife just got home and told me, because she had a meeting, that we were trying to get her into, I guess, your specialty, Lindsay, but because through the Stanford Medical Group, when I guess a psychologist is involved, it might be their policy, but they do not basically allow it to happen in their group. So I know that was a loaded question, but that literally just came with like 30 seconds before this.
Yeah, no, that's really helpful. So it sounds like, I just want to make sure I'm answering your question. Kind of your question is, what in this similar situation, kind of what is the next step if we're trying to determine learning disability that's not yet identified versus maybe ADHD? Is that your question? Yeah,
basically, because my daughter is in a high functioning autism classroom right now. but we notice her schoolwork suffers and she's not there. So it's inclusive with regular ed. And the teachers mean well, but the fix is cutting her work in half, basically. And more they're cutting the work. I don't feel like she's up to do it, but she's definitely not, you know, in a situation where she needs to kind of be in a different environment for education, in my opinion. So we thought dyslexia, me, myself, to be honest, I just got diagnosed with adult ADD. So we kind of was like, I was reading a lot of stuff and got really, you know, sidetracked with all the research in that. And so I thought like, oh, maybe it was that, but then
Adrian, these are great questions. I don't mean to cut you off by any means, but I know that Lisa and Amanda will be talking about this further as we move forward with their presentation. Lindsay, there was a question in the chat. Is Jane receiving behavioral services outside of school or any other therapies?
No, she's not now. So she did for about a year from age 4 to 5. And they worked really diligently with her through a home-based program. And she did great. And family still uses a lot of those strategies that they learned. Now she is, behaviors look a little different, right? So we could definitely consider that. But there are some challenges with that. So at this time, she's not receiving anything outside of school, although she is getting some behavior supports through school, but nothing outside of school right now. And what has historically been hard has been figuring out how that would work best with this family, having one vehicle that dad is typically using during working hours.
Thanks, Lindsay.
So I'm assuming that coming up in the next slides, we are going to talk about what the next step should be for that, right?
Yes,
definitely. For asking that.
Yes, yeah.
So I have a question since you were asking for questions. My question is the inattention during a particular subject, or is it like all day?
Yeah, that is a really good question. It is now all day. So one thing this family could definitely tell you is during math class, she's always been inattentive. Math has never been a favorite for her. But this year feels different in that all day long, they're seeing these concerns.
Anyone have other questions, clarifying questions for Lindsay?
I have like a million questions.
Go for it, Heidi.
Is it only inattentiveness, or is there, I think you said, because you took it away and obviously I need visuals, but is it, there were acts of aggression that she was medicated for? Is that what it said?
Yeah, back when she was 4. And the medicine didn't seem to be super helpful at that time, but the behavior interventions were really starting to be helpful. So we had elected, let's just stop medications, continue with behavior interventions. And that got a little, significantly better over time. And at this point, you know, she is kind of presenting in a different way, right? It's not quite aggression that's the concern. It's more of the being really disruptive in class, because I know you had asked us to take it away. Disruptive in class, unable to maintain attention, having a lot of difficulty staying seated, using lots more breaks and calm down time at school, needing lots of redirection.
All right, other questions in the chat. What behavior interventions were tried?
Since these behaviors started? Yeah, that's also a great question. So school had a behavior plan where they had calm down space and times available for her. They used visual schedules to try to keep her on track during the school day and remind her what was coming next, because transitions are specifically difficult for her. But those things that used to work really well, they were just having to use a whole lot more. And the school was also asking for some help, like what else can we do to support her? Because we feel like these behavioral strategies we've been trying aren't working as well as they used to.
And then there was another question, in a self-contained class, ASD class, if so, how large is the class size?
Yeah, so she was mostly in a mainstream classroom for the majority of the day. For a couple classes, she was in a resource room. Her class size is fairly small, so I'm going to have to try to remember now. I think it was 12 or 13 kids total in her classroom, so it wasn't very big, but she was one of the only special needs kids in her classroom.
Okay. What is behavior like outside of the classroom? Any activities that she attends?
Yeah, so no, she's not in any groups or activities outside of school on a regular basis. She's very active in general. So parents, they were trying to look back and be like, have we noticed a big change in her activity level? And mom, I remember her saying, you know, we live on a farm, like she's outside all the time. She has a four-wheeler, she's chasing the chickens and helping us get eggs. And she's always been super active. And, you know, maybe it has been different in the past year, but they, you know, they also noted that she was allowed to be a really active child where they lived, and it wasn't something that created much of an issue in their home life.
Great, thank you all so much for all these questions. This was really helpful. I'd like to move on to recommendations. Does anyone have any recommendations for Lindsay?
Functional behavior assessment?
Yeah, thanks, Heidi. That's a great idea, and one of the things that we talked about with the school, because it had been probably close to 2 years since school had last done one, and obviously things look different now, so it's probably a good idea to revisit that.
Actually, I think someone else put that in the chat too, a behavior plan.
Yeah.
Maybe collecting some more data to determine the function of behavior. That was what Jackie had said.
Yeah. And kind of along the lines, Adrian, when you were talking earlier, you know, figuring out where is this coming from? Is it because there's some learning issue that we don't know of right now, or is it really ADHD? So kind of further evaluating for that is something that we were also considering as well, to be thorough.
How about a possible sensory diet investigation by an OT, maybe?
Yeah, so kind of working with OT to see if there are some strategies they could help the family try to employ. Yeah, that's a good point, because she at this time wasn't getting OT services at school, but previously had been.
One had recommended, Julie in the chat, telehealth services to maybe observe her in the home, make related recommendations.
Yeah, that's a really good point, because even though, you know, home, we're looking at the behaviors a little bit differently than school. You know, the need to sit and the need to kind of focus is way different in the school environment than home environment oftentimes. And so having some direct observation could be helpful.
Other recommendations?
Oh, Charlene asked how old she's 8 years old, Charlene. And I got a direct message about considering puberty, which is also, I think, a really good point, right? Like sometimes 8 is around the time, you know, you can see some early puberty symptoms, and is this kind of hormonal in nature, possibly. Yeah.
My suggestion, I mean, just something we've tried, is just putting in some of the accommodations that you normally would for ADHD and see if those help resolve any of the issues, in which case you would want to further pursue getting the diagnostics done as well.
Yeah, that's a really good point.
Thank you. Someone had said trying a different chair, a weighted vest, a lap pad, so some sensory things.
Yeah, that's a great idea.
Charlene,
this is Charlene. So I agree with doing the reevals and doing the sensory evaluation with an OT. But in the meantime, I think probably trying, you know, something sensory, trying to figure out what exactly she would respond to, and positively to start using some tools to create like a toolbox. And then once you get a couple things that she responds to that seem to work, you know, making her have a toolbox of a couple things that help her function better in the classroom, then giving her the opportunity to choose those when she needs it. So she starts to develop a little bit of independence, because as she gets to be 10 and 11, she's going to have to be able to regulate herself in the middle school years. And it's going to be harder for her as she gets to be those ages to get her to be able to control herself a little bit better. So at the age of 8 and 9, it's kind of really important to help her figure out what she needs and how to advocate for herself as well. So this is a really good time, crucial time to get the evaluations done and try and figure out a couple helpful things that would help her, with her emotions or behavior, to help her get that toolbox. I know my son had a weighted vest, something soft and squishy, and a couple other things in a box in the corner of the room. He was allowed to get up when he needed something and get it. And then if he needed to do some proprioceptive movement, he had a timer. He was allowed to put the timer on his desk and go out in the hallway. And then when the timer went off, he had to come in the hallway. So he did that in 4th grade. So like things like that I'm talking about. So I think, keeping those things.
Yeah, those are some really great suggestions. I love that kind of allowing the child the opportunity to figure out what does and doesn't work for them with all these different strategies, so we can maybe even build that into the plan that they have, kind of regardless of the diagnosis, right?
Lindsay, there's one final recommendation from SAPNA on our hub. So consider barriers for the family system, possibly having family connected with a medical social worker to assist in limiting barriers that the family may be facing, such as transportation.
Yeah, that's a great idea. I'm glad you brought that up, because that's something I always worry about with this family. So I think that's a great idea.
Thank you all so much.
Yeah, thanks guys.
For all of this. Thanks, Lindsay.
All right, I just wanted to do a couple of quick introductions. I know Amy Newmeyer, Amy, if you want to unmute and introduce yourself real quick. And then Angie Fideli also joined us, and they're on our hub team. So if you want to unmute and introduce, that would be great.
I'm Amy Newmeyer. I'm a developmental pediatrician at Nationwide Children's Hospital.
Hi, I'm Angie Fideli. I'm the Director of Operations for Clinical Programs in Autism Speaks.
Great, welcome. And then Eric, I'm going to hand it over to you.
Excellent. So good to see everyone here. Angie and Dr. Newmeyer, thank you for joining us. Today I have the privilege of introducing two dynamic and just fantastic experts in the autism field. First, let me tell you about Dr. Lisa Nowinski. She is the Clinical Director of Non-Physician Services at the Lurie Center for Autism and is an instructor of psychiatry at the Harvard Medical School. She's a neuropsychologist with more than a decade of experience diagnosing and caring for individuals with autism spectrum disorder, as well as other children with other neurodevelopmental disorders. Dr. Nowinski specializes in the diagnostic and neuropsychological assessment of individuals with autism across the lifespan. Her work focuses on collaborative models of assessment that involve parents and caregivers as active partners throughout the assessment process. She's particularly interested in the assessment of adolescents and young adults with autism, and she's worked to build the Lurie Center's transition-related support services. Dr. Nowinski is also a member of our Autism Care Network's Behavioral Science Committee, where she has worked with professionals from across North America on several initiatives, including several local and national eco-autism initiatives. You're going to hear wonderful things from Dr. Nowinski. And our second speaker today is Dr. Amanda Bennett. Dr. Bennett is a developmental and behavioral pediatrician at the Children's Hospital of Philadelphia. She's also an expert in public health. She has served as a site director for Children's Hospital of Philadelphia's Autism Treatment Network site, which we now call the Autism Care Network. And she's the clinical chair of CHOP's Autism Integrated Care Shared Governance Committee and the medical director of CHOP's Center for Autism Research. She's a busy woman. She provides clinical care to children and young adults with autism and consults in several diagnostic clinics across our hospital with many community partners, both within the Philadelphia region, but also in national contexts like the Native American Reservation in Arizona. It's a fantastic opportunity for us to have both of the speakers. Thank you both for coming.
Thanks so much, Eric. So I'm going to kick things off talking about ADHD and autism. When is it more than just selective hearing or being a kid? So first, let's talk a little bit about what ADHD is. So ADHD is also a neurodevelopmental disorder, but it's marked by different symptoms than autism. So children with ADHD present with problems with attention and focus, or with hyperactivity, impulsivity behaviors. And people refer to ADD back in the day, but nowadays we call anyone with any of these symptoms ADHD, and then there are subtypes. So if you have more trouble with focus and attention, you have ADHD and attentive type. If you have more of the hyperactive and impulsive symptoms, you have the hyperactive impulsive type. Or if you have both, we call that the combined type. Next slide. So thinking about inattention, words that might be used to describe a child who has inattention are distracted. I realize that distracted's on here twice, talk about inattention. So distracted, disorganized, they may be referred to as careless or forgetful. They might lose things, or they might seem like they're not listening, or someone might say that they can't focus on their work. Next slide. Whereas the hyperactive or impulsive child might be someone that fidgets or interrupts other people. They maybe have trouble sitting still or waiting their turn. They might intrude on other people, like the personal space invader in our picture here. Or they maybe just can't play quietly. They might talk a lot or be impatient. Next slide. So the big question that I often get is, well, how do we know this is a disorder, right? Lots of kids have these symptoms. What makes it a disorder? So the diagnosis of ADHD comes when a child presents with several of these symptoms and any of those two categories that I mentioned. And those symptoms, those difficulties have to be present in more than one setting. So a child that just has symptoms in a particular classroom or a particular teacher, I'm not necessarily thinking about ADHD, but if they're having it with multiple people in multiple types of environments, that's more concerning. Also, they need to be interfering with function. In order to say this is a disorder, there needs to be some actual impairment going on. And they really shouldn't be something that you can better explain by another mental health disorder. Thinking along the lines of like anxiety or depression. So a child that has severe anxiety or severe depression that is not paying attention or more reactive, we might want to think a little more carefully about what we're going to call that. Next slide. So then, how common is ADHD in children with autism? It's actually pretty common. Depending on what study you look at, the rates of ADHD in autism range from 30% to 80%, depending on the group. There's been an increased awareness of people having both diagnoses with the latest diagnostic criteria that were published. So historically, we used to believe that if you had autism, you couldn't also have ADHD, although most of us that worked with kids with autism would have disagreed with that long time ago. But with the new diagnostic criteria, we were permitted to acknowledge both of these diagnoses because they are different sets of symptoms. And the majority of kids with autism who present with ADHD will often present with combined type. That is the most common co-occurring diagnosis. Next slide. And there's a few key points that have come out in some studies looking at people who have autism and also have ADHD. There does seem to be some slight increased risk of certain difficulties. So people with autism and ADHD tend to have a little more trouble with their adaptive functioning or their self-care skills than just kids with autism alone. They might present with more cognitive impairments, and they may present with more severe autism symptoms. And all of these things can have an impact on their quality of life. Next slide.
Thanks, Amanda. I'll hop in from here. So now that we know what ADHD is and how it can co-occur in children with autism, it's important to identify what steps you should take if you're concerned that your child may also have ADHD. Next slide. The first thing I want you to do is observe your child, which you're doing already, and start taking notes. This might be on a piece of paper or in the notes app on your phone, but pay attention to how your child focuses their attention, particularly for challenging and less preferred topics or activities. Make sure to watch for both hyperactive and impulsive behaviors, and it may be helpful to ask other familiar adults like teachers or therapists what they're seeing in your child. For example, there may be more demands placed on your child's attention in the classroom setting, and so a teacher may be better able to recognize those symptoms of inattention. Next slide. Once you have some of your concrete examples, I want you to make an appointment with your child's doctor to discuss your concerns. Be open about what you're seeing across settings, thinking about things that are happening at home, at school, at church, or in the grocery store. Make sure to share how those challenges are impacting your child and your family. Have your child's grades slipped? Did they get kicked out of an after-school club or activity? Have you been unable to take them with you on errands because your child's so impulsive that they might run away or grab items from store shelves? So think about all of these things, the impact it's having on your child, and share those things with your doctor. Next slide. Remember, sometimes you may have to request a more formal evaluation with another doctor or specialist, particularly if the signs of ADHD are unclear or if there are overlapping too much with other conditions like anxiety, for example. Next slide. So now we're going to get into some of the specifics about how we diagnose ADHD in a child with autism. Basically, the evaluation process is the same for all children with ADHD. However, your child's autism may make it trickier to identify ADHD and get a formal diagnosis, especially from doctors or providers who are less familiar with autism. Next slide. It's important to remember that there is not a single test for ADHD. You don't need expensive MRIs or brain imaging. And if someone tells you that you do, please look for a second opinion. Observation-based and interview information will be really key to a diagnosis. And these will be combined with information from things like parent or teacher rating forms and sometimes standardized psychological or neuropsychological testing. Next slide. Unlike autism, which often requires a specialist evaluation that you wait for many, many months for, lots of doctors can actually diagnose ADHD. People like your psychologist or psychiatrist, neurologist, developmental pediatrician, or even your primary care physician may be able to diagnose ADHD for your child. This is great news because you won't have to wait for months and months for a specialist appointment like you may have with your child's autism diagnosis. If your doctor expresses concern that it's just autism, or if they can't confidently make a diagnosis, you may want to think about requesting a referral to a specialist, but start with your team, the people who are already in place for your child. Next slide. Once you have an appointment, I want you to be prepared for that visit. So we'll go on to the next slide and talk a little bit about the evaluation process. One of the first and most important parts of any evaluation for ADHD is going to include a detailed conversation or interview with you about the challenges and symptoms that you're seeing. Remember, this is why I want you to observe and take notes, write these things down. Your doctor's also going to observe your child and ask you questions about your child's ability to focus their attention, to regulate their behavior, to manage executive functioning skills like planning, organization, task execution, and self-monitoring. During this interview, I want you to use your notes and be as specific as possible. I also want you to think about sharing videos if you can. This can be particularly important when your doctor is trying to understand what is causing your child to look inattentive. For example, children with autism, some children may be at higher risk for seizures, and something called absence seizures can look like inattention or staring spells. And so seeing that on video can be really helpful for your doctor. Next slide. In addition, your doctor is going to ask you lots of questions. They're also going to potentially ask you and your child's teacher or therapist to fill out some questionnaires. These forms help us to understand your child's specific symptoms and to compare your child's behaviors to other children their age. For example, we know that all young children have trouble focusing their attention for long periods of time, and they can be impulsive now and again. The question is, does your child struggle with these things more than they should for their age, or more than other children their age? Next slide. Finally, in some cases, your child may need to complete some standardized psychological or neuropsychological testing to really measure their skills like attention, working memory, processing speed, and other executive functioning skills. This might include measuring things like their ability to control their impulses or shift their attention between tasks or topics flexibly. And sometimes this direct assessment can be helpful when there are other things that may be causing your child to look inattentive. For example, if things like language processing challenges or anxiety are making it hard for your child to concentrate or stay focused, a more detailed evaluation could give us some really helpful information to tell the difference between those issues. Next slide. So once you have an official diagnosis, there are lots of things that can help. I'm going to talk with you today about a few of the non-medication treatment options and where to start. And then Dr. Bennett's going to talk with you about our medication treatment options. So I first want to just mention that sharing a diagnosis and recommendations from your doctor with your child's IEP team and therapist is really important, and we want you to start there. Beyond that, we're going to talk about 3 major areas to support for sort of non-medication or behavioral supports to address the challenges related to ADHD. Next slide. First, we want to think about how we can change your child's environment to help with their symptoms. This may include things like maintaining a regular schedule or routine, reducing distractions, for example, providing a distraction-free environment or place for them to complete homework, creating systems for organization, for example, systems or routines for cleaning up toys or storing clothes, limiting choices and offering sensory supports. And finally, we do want to pay attention to factors like your child's sleep and nutrition and physical activity level, because if any of these things are off, they can make your child's attention challenges and behavior even worse. Next slide. Next, you may want to access some behavioral parent training to help support your ability to learn and practice new skills to better manage and support your child's attention and behavior. Remember, many of you who were on our first 2 sessions last month have already learned about Ruby, and many of those techniques will be helpful for supporting your child with ADHD as well. In addition, you'll want to review with your child's teacher and IEP team what classroom behavior management tools and strategies are going to help your child succeed. As part of your child's IEP, they may need a formal behavior support plan or specific classroom accommodations like preferential seating, extra time on tests, or technology supports to help them do well in the classroom. Next slide. Finally, just like we pay attention to teaching other skills, right? Social skills, academic skills, children with ADHD may need specific instruction to build their repertoire of executive functioning skills. This might include something like a specific study hall or academic support period that's built into your child's school day, where your child can work one-on-one with a special education teacher or small group to work on things like building their organizational skills, planning for projects, learning better study skills. And it's important as you're thinking about what your child needs to ask your IEP team to create specific IEP goals and objectives that will address your child's specific challenges related to their ADHD and executive functioning. Next slide. Before I pass things off to Amanda, I just want to make a quick note on cognitive training. Just like some people may try to sell you fancy MRIs or brain imaging to diagnose ADHD, you may hear people talk about specific cognitive training programs or neurofeedback. And while these programs may be helpful in improving specific skills like working memory and processing speed temporarily, the research on the lasting benefits of these tools is really mixed. Be aware that sometimes they can be expensive, they may not be covered by your medical insurance. And so I just want you to proceed with caution here if this suggestion is offered to you. I have on the next slide offered just a couple helpful books and recommendations, and our resource team will also be sharing many more resources that'll be relevant for you. And I will pass things back to Amanda now on the next slide to talk through medication treatment options. And I think we can go ahead maybe 2 slides here. There we go. One more. Thank you.
So then this question comes up a lot, right? And I saw someone put in the chat, like they talk to their doctor about their child's concerns, and the doctor said, let's try medicine. So first big question is, when should you be thinking about medicine for ADHD? So if you look at guidelines, the recommendations are that medication should be considered if a child is 6 years of age and presents with ADHD symptoms. However, I will say that there are children, and I saw some conversations in the chat about children under 6 who will receive a diagnosis of preschool ADHD and may benefit from starting a medicine before that guideline of 6 years old. The times that I think about starting a medication, particularly when a child isn't in that school age range, is if their ADHD symptoms are really impacting their ability to participate in school or learn, if their ADHD is impacting safety, if they're having difficulty participating socially in the community and in the activities that they enjoy because of their ADHD symptoms, or if the ADHD is impacting the family's quality of life. Next slide. And Lisa talked about this a little bit, but it is really important to think about other conditions, medical ones especially, that might worsen ADHD symptoms. Sleep in particular, a child that has poor sleep may present with worsened hyperactivity or inattention symptoms during the day. And so it's really important that we're making sure that we address those things that are not ADHD, but might make things look like ADHD. It's also important for a physician to screen for any family history of cardiac conditions before thinking about starting a medication. We'll talk about that a little more in a minute. And I always want to make sure that families are prepared that when we start thinking about treating ADHD with a medicine, there is no one clear path or one right medicine that I can identify in a child without trying it. So parents need to be prepared for a little bit of trial and error, and it may mean trying more than one type of medication or more than one dose before we get to the right treatment for their child. Next slide. So let's take a few minutes and talk about the medicines we use for ADHD. Next slide. So when we look at medications that are approved by the FDA to treat ADHD symptoms, there are two main classes. The stimulants, which are methylphenidate, dexmethylphenidate, amphetamine, dextroamphetamine. These are generic names. There are many, many, many different brands and versions of these stimulants. And then there are the non-stimulants, guanfacine and clonidine and atomoxetine. These are the ones that are FDA approved for ADHD. It's okay, you can go to the next slide. So when we think about pros and cons with these types of medicines, stimulants have the strongest research to back them up. And so when you are talking to your doctor about ADHD symptoms and they recommend a stimulant pretty quickly, it's because the research would indicate that even when you use all those awesome behavioral accommodations and strategies that Lisa reviewed with you, many children benefit most from using those behavioral strategies while taking a stimulant medication. So these medicines are highly effective. 70 to 80% of people are going to see benefit when they take a stimulant medicine. They are also fairly easy to see quickly if they're going to be effective. These are medicines that work in a matter of hours, not over days. I tell families it's kind of like taking an extended release Tylenol. So you take the medicine, it works for a certain number of hours, and then it wears off, which means you'll know within a few days if this medicine is doing something helpful or not. You can also use the medications as needed. So I do have some children that, especially if they're more sensitive or they only need the medication for school, they may only take it on school days. So that's a nice benefit for some families, especially if they don't want their child on a medicine every day. And there are a wide range of preparations. So there are stimulants that are immediate release and quite short acting. They may only last a couple hours. There are others that are extended release that may last up to 10 to 12 hours. There are liquid, patches, capsules, tablets, chewables, all those different versions accessible for children. Now, there are some negatives to stimulants, which is why we have to weigh the risks and the benefits. So they do have side effects. Very common side effects that we see are that most children, while the medicine is working, will have a suppressed appetite. So they often will not feel hungry while their medication is in effect. If their medicine is working too late in the day, they may have some trouble with falling asleep or some insomnia symptoms. And some children, not all, but some may have changes in their mood. So if the stimulant is affecting their mood, they may become a little more irritable or a little more emotional when the medicine is working. Stimulants do not cause tics, but they can lower your threshold. So if you're prone to having any little motor tics or muscle twitches, the stimulant may make those show up a little more quickly or a little more easily. And as I mentioned, there are some very rare cardiac risks with very specific cardiac conditions that if you don't know you have that cardiac condition and you take a stimulant, it could worsen it. That's why we do the screening, so that we know what we're dealing with. And another side effect or another negative aspect of stimulants that I often hear from families is that the medication does wear off. It works for a number of hours. And so a child that has ADHD symptoms 24 hours a day while they're awake, that medicine will eventually wear off. And those ADHD symptoms, that hyperactivity, that impulsivity, that distractibility will come back. And sometimes the rebound effect is a little bit worse than before they took the medication to begin with. So some families see that as a negative. Next slide. Which is why we have the option to talk about non-stimulants as well. So when we think about the pros of a non-stimulant medication, the side effect profile is milder with these medications. Some children might have some drowsiness. There may be some crankiness sometimes with this medicine, or some children may have dizzy spells. The other benefit with these medications is that when you are taking them, they are working all the time in your body. So they're helping to address these symptoms of impulsivity, hyperactivity, attention, morning, noon, and night. The other thing that can be nice is if you have a child that doesn't have combined symptoms, if they really only have inattentive symptoms or hyperactive impulsive symptoms, depending on which non-stimulant you choose, you can target those specific symptoms a little bit more with a non-stimulant. And in some cases, actually quite often, I find that a child who is benefiting from a stimulant but maybe would be needing a higher dose or more frequent dosing might be able to use less stimulant medication if they're also being treated with a non-stimulant at the same time. Now, some of the negative side effects or negative effects from a non-stimulant are that the improvements are not as dramatic. So remember we said 70 to 80% of kids will show improvement with a stimulant. It's not as obvious when your non-stimulant is helping you. And it often takes more time to know if it's going to work. These are medicines that you're taking every day and they need to build up. And sometimes that can take 2 weeks, but sometimes that can take up to 6 weeks. And that 2 to 6 weeks is every time you make a dose adjustment. So it is a longer process to know if this is a medicine that's helping your child or not. You are committing to taking something every day in order for the medication to be effective. And with atomoxetine in particular, there are some reports of very rare cases of liver damage, and adults have had increased risk of suicide. These are not particularly common in the pediatric population, but they are reported with this medication. So we do have to talk about it. I want to make one comment that someone had asked about the Coca-Cola test. So we talked about stimulants being really effective. Caffeine is also a stimulant. So I've had people ask that question before about just using caffeine instead of Ritalin or some other prescription medication. My response is that when I prescribe a medicine, I know exactly what dose of stimulant your child is getting. I know how long I am expecting it to last, and I know how quickly I should be expecting it to kick in and what it's going to do. When you drink a caffeinated beverage, you don't know exactly how much caffeine you're getting in that beverage. And so it's a little bit less predictable, and it's a little harder to know if you're going to see a consistent response with that treatment plan. So my preference is to go with the regulated and monitored medications that I know exactly what we're putting in a child's body. Next slide. So this is just a quick bottom line, and then Dr. Nowinski and I are happy to answer questions. I saw so many popping up in the chat. So we know that ADHD is more common in kids with autism, and we need to be thinking about it and looking for it. And there are lots of people that can help to make that diagnosis of ADHD. It is quite a bit easier, I think, than getting an autism diagnosis in the community these days. Behavioral supports and educational accommodations are really important and absolutely need to be a part of a child's treatment plan, but medications are actually quite effective and in many cases well tolerated, which is probably why your doctor talks to you about medicine for ADHD quicker than we talk about medicine for almost any other behavioral symptom that we discuss. So that's the end of our talk. Happy to open this up to questions.
So Amanda, as you said, we'll open it up to questions as people are getting their thoughts together. I thought we might start with a few that are in the chat. Tell us your thoughts on the impact of medications on brain development for young children. Should we be concerned about that at all when we're thinking about medication treatment for ADHD?
No, so I have to say, there's been some really nice long-term studies now that have looked at children with ADHD and have followed them into adulthood now. And what is really interesting is, so people worry because of stimulants, because I see it just popped up, that people worry that stimulants are addictive, people worry that stimulants are going to have negative effects long-term. What we actually see is that children who have ADHD symptoms who are not treated are at higher risk in adulthood of having negative outcomes. Higher risk of not finishing high school, higher risk of not being able to keep a job, of not staying married, higher risk of problems with the law. So when we look long-term at people who are receiving treatment for their ADHD and doing well with that treatment, we don't see those negative outcomes that we see in children who very much need treatment but aren't receiving it.
That's a great point, Amanda. You get lots of questions for medication here. A couple other questions about whether or not stimulant medications are addictive, and also if a tic is exacerbated by a stimulant, will it go away when you stop the medicine?
Really good questions. Okay, so I can't give you a short answer to the addictive question, sorry, right? So the truth is, if you took a stimulant medicine and you crushed it up and snorted it or injected it straight into your bloodstream, you could get high off of it, but that's not how they're created and processed, right? So the way stimulant medications are made, if they are taken as prescribed, you're not going to become addicted to a stimulant. It's only if you take it not as prescribed that you run the risk of an addiction. And we actually, again, see people who have ADHD but are not treated have more problems with substance abuse in adulthood if they aren't on a stimulant than if they are treated appropriately. The question about tics. So if a person has never had a tic and they are treated with medication and then develop a tic, it is possible that that tic will still be there. But the reason is because that tic was always going to be there. So the stimulants lower your threshold for the tics to appear, but they don't create a tic that wasn't going to be there. I have lots of kids who, if we start a stimulant and their tics get worse or they develop tics, when we take the stimulant away, the tics do improve. They may go away completely, but they may come back because they were there. And if you are prone to having tics when you're under stress or when you're overly tired, you may see those tics still appear. Typically, a child that is so sensitive to stimulants that they're having lots of tics, if we lower the dose or take the stimulant away, that may get a little better.
That makes a lot of sense. Thank you, Amanda. One question that I think maybe we can both touch on a little bit here is the question of whether or not people continue to use medications for life or whether it's common for people to stop medication at some point in time. And before you answer that, I'll just sort of offer that we do know a fair amount about the trajectory of ADHD symptoms across the lifespan. And as children get older, we know that oftentimes hyperactive impulsive symptoms can become less prominent and less problematic. And so there may be kids for whom they sort of outgrow some of those hyperactive impulsive symptoms. I'd also say that if we're doing our job with the sort of behavioral and non-drug treatments, we're teaching lots of skills that are helpful and effective for people with ADHD. And if your child can develop some mastery and independence with those skills, they may find less reliance on or less need for medication. But I'd love to hear your thoughts as well, Amanda.
No, I absolutely agree. So I think that the natural course is that as children mature, some of these symptoms improve just with maturity. I also think as kids mature, they also learn a little bit more of their own self-awareness, so they can recognize when they might need a stimulant medicine, which particular situations they may need help in, and which ones they may be able to be successful without a stimulant. I think also the other thing that happens with age is you get to focus your energy a little more often on the things that you're interested in. So if you pick a job, if your employment is something that is really interesting and you're really passionate about it, your ability to focus on it might not be as impacted as, say, your ability to focus on 3rd grade math or 5th grade language arts. And so sometimes you don't need as much medication when what you're doing is something that's really interesting and stimulating to you in and of itself.
That's great. Let's circle back to Adrian's question from earlier today. He shared a bit during the case presentation, but I think it's an important question about how specifically can we determine if a child is struggling from something like high anxiety, ADHD, dyslexia, right? These are often difficult disorders to sort of tease apart. And I would say, Adrian, to your specific question, certainly all of these disorders, ADHD, learning disabilities, anxiety, all can co-occur. And some children do in fact struggle with more than one of those disorders at the same time. When you have a lot of complicating symptoms at play, this is often when it's more helpful to go to the sort of 3rd step in the evaluation process that I described, where your doctor may want to recommend or complete with your child some standardized testing to really gather more structured information from a number of different sources and in a number of ways to measure some of your child's skills, to evaluate their symptoms across all 3 domains very specifically. And when you're asking about a specific learning disorder like dyslexia, it would be important to have some structured or standardized academic testing and cognitive testing in order for us to tease those things apart. So when you've got lots of questions at play, going to that more comprehensive evaluation may be the right answer. Let's see if we've got other questions. Other Hub team members, if you've noticed things we haven't, please feel free to jump in. I think I'm falling behind on the chat here. Lots of good stories and information shared in the chat as well.
Lisa, there's a few more that just came in if you look at the bottom of the chat there.
All right, I'm scrolling
Some about
down.
natural supplements.
I see questions about supplements. Yes.
Oh, yes, perfect. That did come up. Do you want to tackle that, Amanda? That's a great question.
I can talk about that. Yeah. So so I saw a couple different types of questions asked about this. So someone asked about fish oil and magnesium. So here's what I'll say. When you look at the strongest research for what is effective for ADHD, the strongest research would indicate stimulant medications, behavioral interventions, educational supports and accommodations, the things that Dr. Nowinski and I talked about today. The use of things like fish oil and magnesium sort of have mixed results. So I have some colleagues that may suggest that to families to try, particularly if families are a little bit nervous about trying medication, or if a child is under the age of 6 and we're not ready to quite pull the trigger about starting a medicine yet, but there are some concerns, they may try that first. I think most families don't find those supplements to be dramatically effective enough to manage the symptoms. Either the symptoms are mild if they're benefiting from those types of supplements, or maybe often the child will need another medication to kind of help boost their symptom control as well. There's also lots of things that are sold online and over the counter that will claim that they're going to calm your child. The problem with all of these things kind of falls into the same line as like the coffee or the caffeine drinks, right? We don't know exactly what we're putting in a child when they are taking some of these supplements that are not regulated. We don't know that one dose is the same as the next dose because nobody's really completely checked this out. And some of those supplements can have additional compounds that can be harmful or dangerous. So I'm not a no way kind of doc. Like I need to work with my patients, and I need to know what it is that they're interested in trying and thinking about. But I will read the ingredients and speak up and let them know if I see something that looks harmful or risky. And that's really what I would encourage you to do, going to your own provider and saying, I'm thinking about trying this. What do you know about it? So that we can talk with you together.
That's great, Amanda. We'll take just one last question from the chat. A great question about the formulation of medications. So do all different forms of medications, when we're thinking about tablets, liquids, patches, do they all have the same effect? And how do you know the best way to administer for a particular child?
It's a really good question. So the different formulations there's different chemical compounds under the stimulant category, right? And one child might respond better to one chemical version than another. So that's where that trial and error comes in. It can be really tricky. And the formulation that's going to work best for your child, my first choice is always going to be, what do you think is going to be the easiest for your child to tolerate? Some kids, a patch is great because they don't like putting things in their mouth. It doesn't matter if it's liquid or chewable, they're not eating it. A patch might be a great option for them. But for others, they may really not like something stuck to their skin. And so if that's the case, then we need to think about other strategies. I have some where liquid is great because we can mix it in with other things. Tablets that can be crushed can be mixed into a spoonful of chocolate syrup, peanut butter, you name it. We've tried it in my office. So I think it really is a matter of talking with your doctor about what your insurance will pay for. I would love for everyone to get their medication covered. Don't be paying out of pocket for it. And think about what type of preparation might be the easiest for you to have your child take.
Great tips, Amanda. Thank you. You should all see your closing poll up on your screen now. And so we'll wrap up our questions here and pass it back to the team for the remainder of the presentation.
Thanks, everybody.
Oh, go ahead, Cody. Sorry.
I was just going to say, you guys are going to see the same questions again. It's not a mistake. We're curious if, after hearing the information and having the conversation today, if you guys would answer the questions the same way, or whether you see these questions in a little bit different format. So we appreciate you guys answering these questions again for the second or maybe third time today. We got about 38% people in. So we appreciate you guys taking the time to answer these again.
Great. Andrew, do you want to take us through resources?
Absolutely. So after this presentation, you will receive a certificate, which will verify that you were here and part of the ECHO team today. Also, I do want to let you know, many questions came up. The recordings and resources will be available and shared after the presentation is done as well. We want you to contact our autism response team. You can contact us in several ways. Maybe one thing to really take away is the help@autismspeaks.org email address. You can send us an email with any question about local services or providers that you might be looking for, resources or tools, and our team will be happy to help. And again, that session material after today, we're going to add a few things that you all brought up in the great Q&A and chats, and we'll add those into our ongoing resources. And so we will get those out to everyone as well through a link where you can access all of the resource lists and the presentations, the videos, etc. So here's the number for our team. 188-AUTISM-2 is our main line. We're 9 to 5 in every time zone. If you're Spanish speaking as well, we have a Spanish dedicated line at 188-772-9050. And there's our email address again, help@autismspeaks.org. So please reach out to us with any local questions that you have, resources, tools, and we will be happy to help. Thanks, Amy.
Great. Nancy, do you want to cover these for us?
Hi, everyone. Yes, we would love to get some feedback from you about what you would really like to learn about during our sessions. So go drop in a link right now in the chat. Please give us any feedback that you would like to share. Send us any ideas you might have for future sessions. Next slide. And again, as Andrew mentioned, you will be receiving a certificate if you attended today's session. It'll automatically be emailed to you. So be watching for that within the next 48 hours. Next slide. And again, you will also receive an email that gives you a direct link to the recording and to the PowerPoint slides and to the resources that have been accumulated from today's conversation. So watch your email. Next slide.
Angie, do you want to cover the Care Network real quick?
Sure. Thank you. And this has been a fantastic session. And so just really quickly, the Autism Care Network is focused on improving the health and well-being for people on the spectrum so that individuals diagnosed with autism can receive better care faster and also improve quality of life and continue to expand on research findings as well.
Next slide, there we go.
And for more information on the Autism Care Network, we have a video that gives a nice overview of what the Care Network is. I could talk on the Care Network for an hour. So this is a quick introduction, but please visit autismspeaks.org and search for the Autism Care Network, or you can also go directly to www.autismcarenetwork.org, and you'll see a map right now that lists, that identifies where all of our centers are currently located.
All right, and we have our next session is on November the 18th. It will be focusing on anxiety. We'll get to see the same presenters that we had today, and it's on a Thursday, not a Wednesday. So if you haven't registered, we'll drop a link in there so you can go ahead and register for it. And we are at time, so we're going to give you back